use may lead to some other co-occurring psychiatric may induce some psychiatric disorders such as psychosis, anxiety, and others. Talking about the dependence syndrome, so with the regular use of cannabis, people may develop dependence syndrome, which is typically diagnosed as per ICD-10 as 3 out of these 6 symptoms: the craving, the withdrawal, the tolerance, the loss of control, the preoccupation, the use of despite harm. So presence of at least 3 of these symptoms for a month in past 1 year is sufficient to diagnose a person with dependence syndrome. So on history, when will inquire, the person would report that I experience uh, craving when not taken cannabis. Craving, often they report in Hindi, they may say that talab uthti hai. Then, so this is craving. Also, when they stop taking cannabis, they experience certain withdrawal features of cannabis withdrawal, including insomnia, reduced appetite, lethargy, and others. We will be talking about the other features of withdrawal in subsequent slides. With regular use of cannabis, people also develop tolerance to its use. So they need to take higher dosages of cannabis to get the same effect which they used to get earlier with lower dosages. So maybe a person may get a high earlier with 1 joint, but now the person might need to take 4 or 6 joints to get the same high. So this is tolerance. There may also be loss of control. Despite them trying to control its use, they may just fail. They may also have a prior thinking that I would not take more than a certain amount, like I would not take more than 1 joint, but once they start smoking cannabis, they may find it difficult to control its use. So these are features of loss of control in a person. Then the person would spend more time procuring cannabis, using it, and getting out of its effect. So this is sort of a preoccupation with the use of cannabis, and his other works suffer. Also, they may experience certain sort of harms. Uh, they may have bronchitis, but they are unable to stop smoking cannabis. They may have psychosis associated. They may have some mood disorders, but they still, even after experiencing such harms, find it difficult to stop cannabis use, and this is the use of cannabis despite experiencing harms. So, if a person fulfills 3 of these criteria, three or more than three, then if it is there for at least a month, one can diagnose a person to be suffering from dependence syndrome. So dependence develops in around 9% of the cannabis users. So if 100 people try cannabis, there is risk to about 9% of the individuals developing dependence in due course of uh, uh, their future life. As discussed earlier, there are around 25 lakh dependent users in India. Now, the diagnostic criteria have been slightly changed, although they broadly contain the same components as were there in ICD-10. Here, a more emphasis now is given to impaired ability to control the use of cannabis, increased priority given to cannabis use over other activities, and persistence of use despite harm or negative consequences in ICD-11. Also, these may be accompanied by a subjective sensation of urge or craving, which we have discussed earlier, tolerance, and withdrawal symptoms. The features are usually evident over a period of at least 12 months, as is defined in ICD-11, to make a diagnosis of cannabis dependence. Now, with regard to cannabis withdrawal, the withdrawal is experienced by about 47% of the regular users of cannabis. Its onset occurs after 1 to 3 days, and after 1 to 3 days of stopping or reducing the use of cannabis, it's the withdrawal may peak within 7 days, and within 10 to 20 days, there is a steady decline in the severity of the withdrawal symptoms. So, what are the features of cannabis withdrawal? The features include irritability, anger or aggression, nervousness or anxiety, sleep difficulties, decreased appetite or weight loss, restlessness, depressed mood. Also, there are several physical symptoms including abdominal pain, shakiness or tremors, sweating, fever, chills, and headache. So here we can see that in the initial, after about within the first 7 days, there occurs insomnia, shakiness, decreased appetite. So these are the acute features of withdrawal. Then in about 1 to 2 weeks, there may be persisting complaints related to irritability, restlessness, and anxiety. Beyond that, it is primarily low mood, lethargy, or some irritability, but the symptoms usually decrease after 1 to 2 weeks of abstinence. So the other long-term effect of use, long-term adverse effect of cannabis use includes its effect on memory and intelligence. So chronic cannabis use have a long-lasting or a refractory effect on the attention span, memory function, or cognitive abilities of moderate dose long-term users. So despite them stopping the cannabis for some time, they continue to have these effects, deficits in their cognition and memory. In a large proportion of the users, once cannabis use is discontinued, these effects disappear over several months. Coming to the other psychiatric illnesses which may be associated with cannabis use, the cannabis use increases the risk of chronic psychosis or schizophrenia and chronic psychosis. In people with the genetic risk factors, the risk of psychosis is increased. However, it is still unclear that whether cannabis use itself can produce a schizophrenia in non-vulnerable population. Definitely, cannabis use increases the incidence of psychosis, but whether it causes schizophrenia is still debated. Then, cannabis use increases the risk of anxiety disorders. There is increased occurrence of manic symptoms, and there are higher risk of suicide in people using cannabis. Coming to the physical complications, its effect on cardiovascular system may include hypertension, stroke, and poor peripheral circulation. There is also an increased risk for chest infections, chronic bronchitis, and emphysema in chronic users of cannabis. There occurs alteration in stomach and gut lining. There is associated GI ulcers and bleeding. Also, there are effects of cannabis on the reproductive health. It leads to a decreased sperm count, reduces fertility. Often, it lowers sex drive. Quite commonly, people would come and report that they have a better sex after consuming cannabis. That is because of this loss of inhibition. But with prolonged use, there may be loss of sexual drive. Also, there may be associated preterm labor, spontaneous abortions, and fetal abnormalities. However, the evidences for these disorders are primarily through association studies, and uh, exact causality is still not established. Now, coming to the social complications, the cannabis use is associated with diminished academic performance, high school dropout rate, and delinquency in adolescents. It is also associated with impaired job performance and unemployment. It is associated with financial problems and relationship problems. Also, often the cannabis users face loss of physical altercation in their loss of altercations in their with their family members. So, family related problems also occur. Besides, there are cannabis use is associated with several legal problems. The people often get involved in illicit trade of cannabis, and so it may land them up in uh, legal issues. Cannabis is a controlled substance. It is covered under NDPS Act. Only the cannabis leaves and cannabis seeds are left out of the purview. If, however, if a person is found to have ganja, which is the inflorescence, the person can be punished under law. So, quantities are defined, small quantity and commercial quantity. So, if a person is having a possession of ganja up to 1 kg, the person is said to have a small quantity of ganja, and they can be punished for up to 1 year rigorous imprisonment or fine up to rupees 10,000 or both. For a person having 20 kg ganja, the person is said to have possess commercial quantity of ganja. For that, a person may get a rigorous imprisonment of about 10 to 20 years, and they can be fined for up to 1 to 2 lakh rupees. Similarly, for resin, it is 100 gram and 1 kg, and for THC, it is 2 gram and 50 gram. Cannabis is also often talked about as a gateway drug. So, what is the gateway hypothesis? It refers to an adolescent's early experimentation with alcohol, tobacco, or cannabis, which are usually considered to as soft substances or soft drugs. So, it escalates to more addictive illicit drugs, heroin, cocaine, or amphetamines later in their adulthood. So, cannabis is sort of a gateway to these illicit or hard substances such as heroin, cannabis, or amphetamines. So, that is why it is often referred to as a gateway drug. Now, coming to the management part. So, for management, what we need to do first is to make a diagnosis. So, for diagnosis, what is required? A detailed history regarding the cannabis use pattern. It comprises of details related to the form of cannabis a person is using, the quantity, the route of administration, the duration for which a person is taking cannabis, and the frequency of its intake. Then, for the management perspective, it becomes important that when was the last time the person has used cannabis, the most recent use. Besides, what are the subjective experiences? What are the experiences a person who is using cannabis has with its use? Then one need to explore also about the features of withdrawal. This becomes important with the management perspective. One need to address the issues related to withdrawal. Then the coexisting medical and psychiatric problems also need to be assessed. It also includes assessment for the use of other substances. Quite often, polysubstance use occurs in substance users. Like a person who is consuming cannabis may also be taking alcohol at the same time. They may also be using tobacco at the same time. Often, what people do is they mix tobacco and cannabis and smoke. So, in those individuals, the dependence may not be there just for cannabis, it may also be there for tobacco. So that also need to be taken care of while managing such clients. So that is why a detailed assessment of other substance use is also required. Then assessment should also cover any medical, psychiatric, or social legal complication a person might have experienced, their previous attempts, what might have worked earlier in their abstinent attempts need to be noted down. Based on those, uh, based on that information, the further management could be management approach could be based. Then the family history of cannabis or other substance use or presence or absence of other psychiatric illnesses is also important. Coming to the physical examination, a detailed physical examination need to be done. However, when a person who is consuming cannabis comes to you, you might not be able to find lot many physical features in those individuals. One should look for conjunctival injection, which is quite apparent in people who have recently consumed cannabis. There may be shorty red eyes, then there may be drowsiness or incoordination. There may be associated tachycardia or raised blood pressure, and there may be signs of chronic obstructive airway disease in such individuals. Now, one can also find on the mental status examination several associated psychiatric conditions or psychiatric manifestations, including anxiety, panic, depression, confusion, paranoid ideation, and features of psychosis. Impairment in cognition may be there, which can be elicited through mental status examination, including the impairments in orientation, concentration, and memory. The level of motivation in regular users of cannabis need to be assessed, and the person should also be inquired about their management related personal goals, what the person wants to achieve from this abstinent attempt. Now coming to the urine toxicology screen, urine toxicology can be used in uncooperative patient. A person who is using cannabis may have their urine testing positive even for 3 or 4 weeks after stopping cannabis use, because the THC gets released slowly from their lipid stores and is detectable till late in users of cannabis. However, the urine toxicology is not recommended in regular practice, and one should better go with the person's or the patient's version of their substance use. There are several screening and diagnostic tools as well for cannabis use. For the severity of dependence scale can be used. Cannabis abuse screening test is a short screening test for cannabis use. Cannabis use disorder identification test can be used. Assist, which involves screening for various other addictive substances, also can be used for assessment of cannabis also. And cannabis withdrawals can be rated on cannabis withdrawal scale. Now coming to the management part, we will discuss about the management of intoxication, withdrawal, dependence, and cannabis-induced disorders. Regarding cannabis intoxication, often the reassurance and supportive care is usually sufficient to for a person who is having cannabis intoxication. The person can be placed in a dimly lit room with with lesser stimulation, and after about 1 to 2 days, a person would become absolutely fine. No other treatment may be required for such condition. Is intoxication. When a person presents with distressing anxiety, they can be given short-acting benzodiazepines to relieve their anxiety. In cases where there are severe and disruptive psychotic symptoms, low-dose antipsychotics can also be given, like olanzapine, risperidone, or haloperidol. So they can be used to acutely manage the patient, but is not required to be given to the patients for long term. Regarding the cannabis withdrawal is again a clinical diagnosis based on the features of withdrawal present in a patient who has reduced the use of cannabis. The symptoms are mostly transient, mild, and self-limiting. Often reassurance and supportive care is usually sufficient. For the management of cannabis withdrawal, no drug is approved till date. Only symptomatic treatment with benzodiazepines for anxiety or insomnia or low-dose antipsychotics or antidepressants again for insomnia or anxiety can be given in patients experiencing cannabis withdrawal. Regarding the management of cannabis dependence per se, the diagnosis is with detailed history from patient and family. We would inquire about the features of dependence, and if a person fulfills the diagnosis of dependence, then we can proceed through the management for dependence. The treatment can usually be done through outpatient basis. However, in patients who are unable to reduce or abstain from cannabis in outpatient setting, or they are presenting with psychotic symptoms or posing threat to self or others, can be hospitalized also. So inpatient treatment can be given to them. Currently, no medicine is approved to treat cannabis dependence, although lots of medications have been tried. This includes the mood stabilizers, including divalproex, gabapentin, lithium topiramate, the antidepressants, fluoxetine, escitalopram, vilazodone, nefazodone, mirtazapine, venlafaxine, bupropion. Antipsychotics have been tried. Several cannabinoids, the dronabinol plus lofexidine combination, the nabiximols, they have also been tried, but not found to be better compared to supportive treatment. Besides anxiolytic medications such as buspirone, stimulants, hormones, and several other medications such as N-acetylcysteine, naltrexone, and neuropeptides have also been tried in the management of cannabis dependence. However, no substantial benefits have been found with regard to the outcomes in patients with cannabis dependence with the use of these substances. Now, the management of cannabis dependence usually involves lots of psychological and behavioral interventions, which includes the motivational enhancement therapy, where a person is helped in recovery through making them set concrete personal goals that they will be motivated to achieve. Their motivation is assessed. We have assessed the motivation in through mental status examination, and then it can be worked to further enhance the motivation. The individuals are then helped to formulate plans to meet their personal goals which they want to achieve, and they can further be guided to towards complete abstinence. So let's say if a person is in pre-contemplation phase, the motivation can be increased to at least contemplate about abstaining cannabis. Those in contemplation phase, they can be motivated to prepare to abstain. Those in preparation phase, they can be motivated and worked upon to actually act on abstaining cannabis. And then we work towards maintaining the person in an abstinent state. So motivation enhancement therapy is done. Also, CBT has found to be effective. It uses counseling and education to help people in recovery to recognize dangerous behaviors and counteract them with healthier choices. So it can also be used to sort of find those behaviors in which person can engage, and that can help the person going back towards their earlier use of to the use of cannabis like they earlier used to do. Also, contingency management has been found to be effective. In this approach, tangible rewards like reward vouchers or prizes are given to the person to encourage a healthy behavior, such as remaining abstinent from drugs. So, compared to the pharmacotherapy, there is more evidence for psychological and behavioral therapy in the management of cannabis dependence. With regard to the cannabis-induced disorders, the cannabis-induced psychotic and anxiety disorders rarely persist beyond the period of acute intoxication. So, if intoxication is there for a day, the person would just be out of these psychotic and anxiety symptoms after that duration. Confirming a diagnosis is important, that whether it is just cannabis-induced disorder or it is an independent disorder which has reoccurred or relapsed. So, what is required is a close monitoring of the patient, reassuring the patient, because these symptoms often usually abate in 5 to 8 hours, and symptomatic treatment can be given, such as benzodiazepine for acute anxiety. If the symptoms persist beyond 24 to 48 hours, it suggests that there may be another psychiatric disorder which is responsible for these symptoms. The persisting psychosis may require antipsychotics, and antidepressant may be needed if a person is having cannabis-induced depression. The symptoms persisting for more than 1 month in abstinent patient indicates independent psychiatric disorder. Now, just briefly talking about cannabis decriminalization and legalization, which is a talk quite commonly talked about topic nowadays. So there is an ongoing global debate over whether to decriminalize or legalize cannabis use. So what is decriminalization? It is the lessening or elimination of criminal sanctions for the cannabis use. And what is legalization? It is removing a legal prohibitions against cannabis use. So here it is not in decriminalization. What is being said is eliminate the criminal sanctions. In legalization, what is being talked about is to just legalize the use of cannabis use. So there are some arguments against this in this debate, like removing criminal sanctions will increase the use of cannabis. There may be also there are several cannabis related harms which may increase, such as psychosis, crime, antisocial behavior, accidents, etc. However, there are several arguments in favor of decriminalization and legalization, which includes criminalization is expensive and has not proved effective. Like people who are found to have cannabis, they are put in jails. So what it will lead to is an increased burden over law enforcement and criminal justice resources. Besides, there will be overcrowding in prison. Also, if this substance is decriminalized, then there will be a decrease in the illicit trade. So there will be a subsequent increase in organized crime. So this is one argument in its favor. Also, they have told that there are health effects of cannabis. Also, medical marijuana is gradually being more and more promoted in West. And they have also debated that the overall harms are lesser with the use of cannabis than alcohol. So why not putting alcohol under control? Why only the cannabis, which is found to be more safer than alcohol, why is it put under so many regulations? So these are some arguments in favor. However, it is yet not clear whether legalization will have a net positive or negative effect on society. So the debate is still. So this is all for this presentation. Any questions are invited.
Thank you, Dr. Amit. That was a wonderful presentation. I don't think we had discussed cannabis during the last 1 year, and he has brought out very lucidly about the nuances. More so in being the gateway drug, it is increasing of late, and we need to be concerned about this because we'll be handling it directly. Any query they might put in the chat box or unmute themselves and please ask. Yeah, student, any query, you can write in the chat box or you can unmute and ask also.
So there is a question put in the chat box regarding the medicinal use of cannabis in Parkinson's disease. So, sir, with your permission, may I answer?
Yeah, please.
Cannabis has been used in not many neurological and psychiatric disorders. They have been studied. However, there is still not much convincing evidence to suggest the use of cannabis on a regular basis in these disorders. Apart from the several conditions in which I have earlier told that it is approved, there is still ongoing research, but till now it is not an established indication for the use of medicinal cannabis in Parkinson's disease.
Yeah, second question is, how long do we continue treatment for cannabis-induced psychotic disorder?
Sir, for cannabis-induced psychotic disorders, usually if it is cannabis-induced, it is expected to resolve within few days as soon as the intoxication phase of the cannabis gets over. So usually in few days, psychotic presentations get improved spontaneously with little interventions required, such as the use of antipsychotics or benzodiazepines for the management of anxiety or agitation. But if it persists, then we need to seriously think that whether it is a relapse of some independent psychiatric disorder, and if it is so, then we might need to continue the medication in the patient for long. However, for cannabis-induced psychotic disorder, per se, no long-term treatment is indicated.
I think there's one question. Can cannabis lead to manic symptoms?
So, sir, the short answer is yes. The cannabis may have anxiety-related manifestation. It may be having manifestations on the psychotic spectrum. There may be manic symptoms with the use of cannabis. So, yes, cannabis can lead to manic symptoms in manic presentation in people using them.
Okay. Another question is anti-craving agent in cannabis dependence.
So, lots of anti-craving agents have been tried, which are used as in other disorders, such as they have used naltrexone, which is an opioid antagonist used for alcohol dependence syndrome as an anti-craving agent. They have used varenicline in the management of cannabis dependence also. Also, N-acetylcysteine has been used. However, till date, there is no clear advantage of using these substances. So, as I have shown earlier, there are lots of medications are used, but none of them has a substantial evidence till date for which we can say it should be used in cannabis dependence. So, for if the person is having anxiety, some anti-anxiety medications can be given, but per se, no anti-craving agent is approved for use in cannabis dependence.
Please suggest any material on further read on cannabis. So, if you remember often.
So, some good sources may be one is your textbook, the comprehensive textbook of psychiatry. The other may be a recent publication in Lancet. I believe there is a special issue on cannabis use disorder only. So there is I believe 10 pages, 7 to 10 pages review. It has comprehensively discussed cannabis. So that these are the two sources I would suggest you can refer to.
CTP पढ़ लें तो 60 तक आ जाएगा उसकी, अगर वो ढंग से पढ़ लिया जाए. बाकी फिर रेफरेंस मटेरियल you can use that. Can we use term like cannabis induced mood disorder for diagnosis? The DSM doesn't mention it.
If it is not mentioned in a diagnostic system, it is wise not to use those terms. Go for the diagnostic system where it is included. So cannabis-induced mood disorder is or bipolar disorder is not there in DSM. However, they usually categorize or classify those individuals with these symptoms into cannabis-induced psychotic disorders. So, depending on the diagnostic system which you are using, an illness can be placed. Just go through the diagnostic criteria mentioned and appropriately place the patient there.
Yeah, I think we are ICD-10 country, we should be using it. And for every diagnosis, there is a category, either in the main heading or the subheading. So accordingly, you can one can choose that. There should not be any issue. The main thing is that you should be able to put it in a, see, things will keep on changing. Now you will be finding shit, we have been in the transition phase of 9 to 10, you all will be from 10 to 11. So there are still people coming for evaluation of things of diagnosis basis of ICD-9. You should be knowing that these are the set of symptoms and where you put it in. It is mostly about classificatory system, but the phenomenology, understanding and treatment, you should be much more aware, because this will change gradually rather than the sudden shifts between classifications. I think
there is one question regarding the availability of cannabis in India for in Ayurvedic medications. So, as I have told earlier, bhang is legal in India. The cannabis leaves can be used. It often you can see, you will be able to see bhang ke theke or bhang shops in northern India, because bhang is legal. The leaves, the products from the leaves are legal. Ganja, the inflorescence, it is illegal. So one cannot sell this ganja or hashish or charas. Bhang, the products which comprises of bhang, it is legal.
yeah, I think there are no more query. If there is none, thanks a lot, Dr. Amit, for such a wonderful lecture and subsequent discussion. And with this, over to you, ma'am, Nodal Center at NB for final closure.
Thank you, sir. Thank you, Dr. Amit, for the presentation, and thank you, Dr. Prakash, for joining us. Thank you.